Hello. Let's review preseptal and orbital cellulitis. It's kind of a profound picture of a preseptal cellulitis. So preorbital infections can be divided anatomically two ways. The preseptal cellulitis, which is anterior to the orbital septum, or orbital cellulitis, which is posterior to the orbital septum. The distinction is imperative because infection in the orbital apex and beyond can cause blindness in about 11% of the people, and it can be potentially fatal. Epidemiologically, cellulitis is most common in children. Preseptal cellulitis is much more common and frequent than post or orbital cellulitis, the posterior, and that's a more positive thing. However, orbital cellulitis and preseptal cellulitis can occur in any ages. Interesting, the male frequency is double of female. Pathogenesis, there's usually three sources of infection. A local spread from an adjacent structure like a sinus or a tooth. After local trauma. And third, bacteremic spread from a remote foci. 90% of all cases of orbital cellulitis are caused by an acute or chronic sinusitis, usually the ethmoid sinusitis. And on page 351, they will list for you the causative organisms. They're usually Streptococcus or Staphylococcus aureus, including MRSA, okay, methicillin-resistant Staphylococcus aureus, but Haemophilus influenza, Moxarella catarrhalis, are also present, but less so because, especially the H flu, because we have vaccine against it. In children, the majority of the cultures are typically positive for staph and strep, but also there's polymicrobial. Patients over the age of 15, they're more likely to have polymicrobial, and in immunocompromised or diabetic patients, a fungal-caused aspergillus or mucor should be considered. The clinical presentation of cellulitis, the physical exam will reveal the characteristics of either anterior or posterior. Preseptal cellulitis, the patient usually presents with unilateral eyelid edema, warmth, erythema, and it may be severe like in the photo, previous photo. However, the eyeball itself is usually spared. And that's a cue and a clue also. In contrast, orbital cellulitis presents with axial proptosis, lid swelling, conjunctival chemosis and injection, elevated ocular pressure, pain and restriction in movement, and the patient may report decreased visual acuity and diplopia. Almost always unilateral presentation, just one eye or one side of the face. The patient can have a fever with either, with the preseptal or the orbital, but usually you're going to see systemic malaise associated with the postseptal disease. Physical exam, thorough PE must be rendered and provided. You've got to get vital signs, mental status, assessment of neck flexibility, visual acuity, pupil response, extraocular muscle function. You're looking for pain, really a comprehensive eye exam, as well as, looking for signs of trauma, retained foreign body. So you're really doing a thorough, comprehensive exam. Diagnostics, management, and treatment. Orbital cellulitis, it requires urgent hospitalization. Okay, so that's why it's so important to go over this information. However, preseptal, the patient can be started on an oral broad spectrum antibiotic such as a third generation cephalosporin or Augmentin, but the follow-up needs to be really close, 12 to 24 hours, and that needs to be reiterated. Again, please note that orbital cellulitis or the posterior is potential fatal and can cause blindness. So referrals, we refer to ophthalmologist for preseptal cellulitis that fails to respond within 12 to 24 hours, or if the patient has decreased vision, proptosis, diplopia, restricted ocular movement, systemic or neuro symptoms. Patient education and health promotion, your orbital cellulitis posteriors are going to be in the hospital. The preseptal, if you prescribe them an antibiotic, you do educate them again to return in 12 to 24 hours. There should be no tolerance, zero tolerance for worsening of symptoms, and they need to complete the full course of their therapy, their antibiotic given. Thank you for your attention.